Thank you everyone for coming and thanks for the invitation to speak today. My name is Ken. I'm one of the clinical research fellow in AMIC. The picture behind us is the CT scanner in our center. Every day it serves dozens of patients presented with chest pain or breathlessness symptoms to find out if this is related to the heart. And cardiac CT scan has become one of the first-line non-invasive tests to visualize the heart vessels to see if there are any significant narrowings of the heart arteries due to the buildup of the plaques, as we can see in one of these the plaques. And with the improvement of the scanning technology, we can now see the heart and vessels in much more details and efficiently. And for example, the scanner in Oxford can acquire these images in as quick as a single heartbeat. And that gives us a very useful diagnostic information to plan for invasive procedures if we found any significant narrowings of the arteries, to plan for the procedure to unblock the arteries to help the patient. For a very long time, up until recently, the focus has been how narrow the artery is, which delivers oxygen to the heart muscle, and the fatty deposits that builds up the plaques in the heart artery wall, narrows the heart artery and reduces the blood supply. And if it ruptures suddenly, it forms blood clots that can block off the heart arteries and causes an emergency and acute heart attack. But is it all about just the plumbing of the heart arteries and relieving narrowings of the artery? Let me tell you a story. Mr. J is a 52 years old gentleman patient of mine who over the years had several heart CT scanned because of chest pain. And as you can see, there were no real significant narrowings of the heart arteries, and he was reassured. He's usually quite active and not much other medical problems. But only a year later, he came in as an emergency with an acute heart attack. And as you can see, the artery that was at that point is almost completely blocked. And he ended up needing a bypass surgery because of this. His case is not the only story in the country. In the Oxford Risk Factor and Non-Invasive Imaging Study, we analyzed 40,000 patients who had a heart CT scan, and we followed them up to see if there are any significant major cardiac events, like dying because of cardiac problems, heart attacks, or heart failure. And as what we suspected, only a minority of patients had significant narrowings of the artery in the heart CT scan. By far, the majority showed no significant narrowings of the arteries with just minor plaques and fatty deposits on the arteries, and they were usually reassured and get on with their lives in the community. But what we found is that because there are so many of these patients, 2/3 of all the heart attacks actually occurred in this population of people. And this contributes to the unmet need of the scale of the problem we're facing for the cardiovascular disease in this country, affecting 7.6 million patients, and every 8 minutes someone dies from the coronary heart disease, and this is putting a lot of pressure financially to the health system. So how do we address this? Now we have to look before the heart attack occurs, and one of the major the problem of the heart arteries that we don't capture in the current practice is the inflammation of the heart arteries, and it drives the smaller non-obstructive plaques to rupture and causes acute heart attack. And if we can detect inflamed plaques, these are very vulnerable plaques that are at risk for rupturing and causing a heart attack, we can predict the cardiac events and actually deploy preventative treatments earlier to prevent this. So the basic science discovery from our lab led by Professor Antoniadis over the last decade have found that the fat tissue around the vessel is not just providing support and protective of the vessel. It is actually has got quite a lot of involvement in the metabolism of the heart arteries, as you can see in this, and in the inflamed arteries, it relays chemicals such as cytokines, for example, that affects the fat tissue around the heart vessels. So the fat cells become smaller and more watery, for example, and this can be detected non-invasively on the heart CT scan. So we can, by imaging the fat tissues around, we can tell whether the heart vessel is inflamed or not. So this can be applied on the over 200,000 CT scans that are done in the country, up and down the country in the UK. And we can see that 80% of them didn't show significant narrowing of the heart arteries, for example, like these two cases. And with the technology, we can now see the dark area next to the arteries, which essentially was fat. Some of them was inflamed, which shows red indicates the arteries is inflamed, and the yellow is the healthy fat tissue, which suggests that the vessel is got low inflammation. And so we can see the changes, and more importantly, to measure and quantify how inflamed the heart artery is. So how does that help us to predict heart attacks? Now, in the orphan study, we follow patients up to see if there are any heart attacks events over the 8 years. And if there are no inflamed arteries, as you can see, the rate of heart attacks is not sort of dying from heart attack is not very, very high. If you have one inflamed arteries, it increases your risk of dying from cardiac cause over the follow-up period. And if you have 2 or 3 inflamed arteries, it increases your risk significantly. And for those patients who had 3 inflamed arteries, or all arteries in the heart vessels are inflamed, they have almost 30 times higher risk for dying from cardiac cause compared to those with no inflamed arteries. So in the real-world clinical practice, how does this fit in with everything that we know that predicts heart attack? Because it is important to know that diabetes, smoking, blood pressure, these are all very important factors affecting the risk for heart attacks, and as well as the narrowing of the arteries that we measure on a day-to-day practice. And we can combine all these into an AI model to essentially combine all these factors that do give us a single scoring of how likely the heart attack would occur in the next 10 years, in the next decade. And with this scoring, we can generate kind of like a traffic light system of how high is the risk. So if it is green, perhaps lifestyle changes, stop smoking, or so healthy diet. If it is on the yellow zone, maybe we should think about tablets. Statins is a very good lipid-lowering medication. And if it's on the red, then it's quite high risk, and maybe we should go very heavy-handed with any anti-inflammatory treatment. And in the orphan study, the AI model tells us the risk of dying from cardiac causes over the time. And so the green, the very low-risk patients has very low rate of dying from heart disease over the 10 years compared to those medium and very high risk. And interestingly, these almost overlap the actual events that we saw in the actual study. So these are the predicted events overlapping the actual event that happens in the studies, in our study. And that shows the performance of the AI model to predict future heart attacks. So if this technology was available for our patient, Mr. J, perhaps we could see the changes earlier and actually start preventative treatment, such as statins, anti-inflammatory treatment at this point, and maybe we can prevent a significant clinical event. Now, implementing the technology is almost as important as the innovation itself, and this has been piloted in a number of the NHS hospitals and using similar categories to guide the preventative treatment strategies. And from the initial results, we saw that it changes treatment in 45% of patients, and this is compared against the best clinical guideline that we have at the moment. And it changes 45% of treatment above and beyond what we could do in the current practice. And projecting the changes in the treatment and how does it impact on the outcomes over a lifetime, we see that it reduced the number of heart attacks, heart failure, stroke, and dying of cardiovascular disease over a lifetime horizon, and that shows the potential impact it could help if we were implementing this in the practice. So it has been quite a long journey from the scientific discovery of the technology of measuring inflammation of the heart arteries from the CT scan, all the way to implementing this in the day-to-day practice with the ultimate goal to help the health system and, more importantly, to save lives. And that cannot be done without the support from various funding bodies. And so what is the next step? The orphan study, the Oxford Risk Factor and Non-Invasive Imaging Study is still ongoing. We aim to include 250,000 patients over the country and across the world. And we aim to recruit 200,000 patients in the UK. And at the moment, we are almost over halfway. And importantly, it includes a very ethnically diverse population. And that reflects to the patients that we see day to day that comes for CT scan for heart problems. And with this data, we can start to address something that's close to my heart, that some socioeconomic disparity in the health outcomes. And we know for a fact that the people who are less well off has worse clinical outcomes. And with this data, we can see if there are any measures or markers that we can see on the CT scan that can help address the higher risk in this population. So with that, I want to thank my mentors and the orphan study team, as well as the team in the AMIC. Thank you very much.